Welcome to this first plenary session of Day 2 of Rhythm Intervention Online 2023. I am Julian Chun, and we have a great session in store. A live case, simplified mapping and ablation of iatrogenic AT using the Carto mapping system in, and this is also interesting, the day surgery setting from Rio course director Richard Schilling from his center, One Walbeck in London. Before we join our case center, let's meet our spectacular and fantastic panel for the session. We have Duraj Gupta from Liverpool, UK, Claire Martin from Cambridge, also UK, and Vivek Reddy from New York, United States. A reminder to all our participants out there to keep submitting, please, questions for our great faculty. Without any further delay, let's move on and hand over to Richard in London.
That you've got on there. Hi guys, can you hear me?
Wonderful, Richard. We hear you, we see you. Perfect.
Okay, so I thought I'd try something a bit controversial today, and I thought we'd do some electrophysiology. So
Great.
Rather than create a sort of dynamic map, I've just created a geometry, and then I thought we'd go through some basic electrophysiology with the audience. Now, my workflow has been slightly thrown by the fact that this chap has already got a PFO, and one of the wires went through the PFO. So I've only had to do one transeptal puncture. But Sachin Shah, who's our anaesthetist, is brilliant at the TOE. And so I'm just going to get him to show you some of the images from the esophageal image guided transeptal. You may notice that none of us are wearing leads, apart from those that are cold, because we aren't and haven't used any X-ray yet during the procedure. So Sachin's showing, do you want to talk them through what they're seeing there, Sachin?
Yeah. So let me just bring up a standard bicaval view. So you can see here, there's one wire which has already gone through the PFO, and then there is another wire which is going from the IVC into the SVC, where, Richard usually does a drag down onto the septum. So let me bring up another image.
Can you record on the LA? Thanks.
To see that there is a tenting with that drag down on the thin part of the septum. At this stage, I then go down to 0 degrees to show him the septum, which you can see with the tenting. And then he uses a safe set to sort of go through the septum, and I can bring up one of the more images where you can see the wire going through the septum, the safe set, and then I'll show him the appendage and the vein, and you will be able to see if I've not got the loop here, but we saw the wire going into the left upper pulmonary vein. Let me see if I've got another image to show that. No, so then he goes through the septum with the dilator, and then you can see a sort of a tram track appearance of the dilator here. So that's the first puncture. This time we had the second wire going through the PFO. So hence, he just went through the second wire, and then you can see the two tram tracks over there in the left atrium. I think that's me, isn't it, Richard?
Great, thank you. Thanks very much, Sachin. So what that means is having someone like Sachin helping me during this case means that I don't have to wear lead. Can you record on that, on the left pulmonary vein, at all during the case? So what we've done is we've created two geometries. The first is of the left pulmonary veins, and the second is of the left atrium. And that means I can switch the veins on and off if I want to. So this is a 76-year-old man who's had a previous AF, persistent AF, treated with cryoablation. Can you tidy up the geometries, guys? And I'll just while I do this. And so he's had cryoablation. He's been on amiodarone, which I'd normally put people on for a month or two after the procedure. And he's had an early recurrence of a regular atrial tachycardia. And so our plan today is to check the veins and make sure they're isolated and re-isolate them if we need to. And then, sorry guys, it'll be easier if you take off the veins, get rid of the veins on the LA, and then that's great. Check the veins are isolated, re-isolate them if needed, and then map the atrial tachycardia. Now we can already get quite a lot of information about the tachycardia from the electrograms we have in. If you look at the Carto geometry, you can see I've got 4 pulmonary veins, I've got a left atrium, but the CS is way below the left atrial body, and that's because I've just not been able to reach, because he's got a big atria, because he's got persistent AF, I've not been able to reach with the PV catheter. So I'm missing a bit of the geometry, but you can see the CS is in the conventional CS position. And if we look at the electrograms, and I think we're going to show you those on the screen as well, which on number 2, the live screen. You can see that. So we can see CS proximal leads, but it's not a massively steep activation. So bearing in mind that atrial tachycardias can only be one of 5 things, and I hope I can remember 5 things: right atrial flutter, mitral isthmus dependent flutter, roof dependent tachycardia, a pulmonary vein re-entry, or a focal tachycardia, or a tachycardia coming from around some scar that's either iatrogenic or inherent in the patient. So far, we're looking at it's either a mitral isthmus dependent or a right atrial flutter, given the CS activation. But because it's not that steep in terms of its activation sequence, it could still be roof and just hitting that CS 7, 8, 9, 10 earlier, but coming down the roof from superior to inferior. It can't be going the other way. It can't be going round the mitral isthmus and underneath the veins and going up, because otherwise you'd see 9, 10 and 1, 2 both early and 5, 6 being late. So we've already got quite a lot of information about the tachycardia before we've even started.
Maybe if I can ask for our audience also just a very principled question in the very beginning. Of course, it was beautiful to see how you managed to go over without any fluoro, and I do envy you with not in being in need for wearing lead in the AP lab. That's amazing and great. But what would you do typically? Would you always go right away for the left to enter the left atrium, or would you also do some, let's say, basic analyses of electrograms to consider? And you mentioned also CTI flutter as a potential option, and or because you want to go straight away for potential re-isolation after cryo-index procedure. Just a very, very brief comment on this.
Yeah, so my logic is I'm always going to check the veins and re-isolate them. So I start in the left and then go back to the right, because it's just easier for the workflow, because once I've done my puncture, Sachin will take the TUE probe out, and the patient's then left without a probe down. So I'll just show you the PV signals, if I may. So we're in the right lower, and I think there is a signal there on 17, 18, 9, 10. I'm just going to pull it right to the back of the vein. And so we can see that maybe 3, 4 is the earliest. And if we can have a right lateral on the right-hand view, we can see that 3, 4 is just on the anterior.
The electrograms in the Carto, but not on the large screen. So
can we have the electrograms on there as well, please? Let me know when you see those.
Now we see it. Yeah, now we see the.
Yeah, great. So 3, 4 looks slightly earlier, and you can see on the Carto. Oh, sorry, that was me. Sorry. Can you delete that? 3, 4 slightly earlier, and 3, 4's on the anterior superior aspect of the vein. So whether that's a vulnerable point for the cryo, and normally I think it's on the inferior aspect of the vein, but that seems to be where it's breaking through. Can I get you to zero the force, please, guys? Well, just zero the force on the map, and then let's put the mapping catheter near there. Can I have AP on the left-hand view? And if you can put the mapping signal, mapping's on 16 on the BARD, and So to just keep things simple, I'm going to isolate the veins first so that PV re-entry is not in the game. And just, trying to make life as simple as possible, because I'm going to isolate the veins anyway. And if that stops the tachycardia and there's 2 breakthroughs, then that'll be PV re-entry. Can I put the map just above 3.4 on the BARD? Just above 3.4 on the BARD, so everyone can compare that timing with the PV 3.4. 30.
So Diraj, would you do, and I see you nodding, probably you would also have a very similar workflow in your lab in Liverpool, or how would you comment on that?
Yes, thanks, Julian. Yeah, it helps that I trained with Richard all those years ago, so it won't be a surprise to anybody that my workflow will be very similar to his. I just wanted to inquire from Richard whether he's tried entrainment from the proximal and distal coronary sinus electrodes, because I find that quite helpful as well, not only to look at the activation sequence of the CS electrodes, but also activate, entrainment. If, for example, entrainment is in from both proximal and distal coronary sinus electrodes, then I think is a perimitral flutter, which could be counterclockwise or clockwise, depending upon the activation sequence. If the entrainment is well out from the distal coronary sinus electrodes by over 100, then it would be suggestive of a right atrial flutter and that kind of thing. So I don't know if Richard has tried in training the tachycardia at all so far.
Well, I'll come back to that. But I just wanted to briefly show you the vein. Can you show me a PA view? So I've just swept the catheter around the veins very briefly, and you can see there's not really much signal on the posterior wall. Inferior wall with the mapping catheter, not much. And then AP, please, on the left. And then just in the, rotate the left view around to the right very slightly. There's just a really low amplitude, long signal you can barely see on the map. So I'm just going to go there and see if that trims off that PV, and then I'll answer your question, Diraj. FTI 3 to 400, please, on the Carto. Lovely. So I'm using FTI 3 to 400 because I'm not convinced I understand the ablation index and what it means. I've just been using force time integral for many years, and I just keep the power 30 on the back wall and 40 on the front wall. And so far, I've never had a tamponade, an esophageal fistula. So for me, that's a reasonable strategy. So I'm going to do 2 speculative burns here, and then I'm going to leave this vein because I'm not sure how important it is, because I want to get to the action and we'll deal with the vein afterwards. So in answer to your question about the entrainment, Diraj, I see these atrial tachycardias a bit like trying to find a very rare bird, and I'm trying to sneak up on it, and I don't want to scare it. And so I think that if you entrain, there's a pretty good chance you could change it or stop it. So I focus on understanding the mechanism with activation mapping first, and then I worry about the entrainment if I can't clearly identify what's going on with activation mapping. Is it 2 mil Visitags, please, guys? Because I think we're on 3. So my preferred is 2, thanks. So nothing's happened there. And I'm going to come back to this in a minute, I think, rather than get bogged down with this. And let's have a look at the tachycardia. Go PA, please. Before I do, I just want to show you the right upper is silent. The left lower is silent. And then if I go into the left upper, if I go really far in, you can see it's silent there. If I go a bit further in, you can sometimes see a signal, and that's the appendage. And we'll recheck that later on and make sure it is the appendage. But the clue is on 1112 on the left lateral view, left lateral, you can see 1112 is sitting right next to the appendage on the right-hand view of the Carto, and that's picking up the far field appendage. So I'm happy all the other veins are isolated. So I'm now going to put the PV into the appendage, and I'm going to use that as my reference. And the reason I do that is because It's a very atraumatic catheter. It doesn't cause ectopy like sometimes the Pentaray can. And it's very stable once it's in the appendage, so it ain't going to move. And if this is a left atrial tachycardia, then it's closer to the source than perhaps the CS is, and it won't get confused by far field V. So that's why I'm going to use that as my reference. And I'm going to go really old school, and we're going to do just a map with the ablation catheter, point by point, and see what we got. So we can see that PV1314 is the earliest on the map, which implies that the activation is hitting the appendage first on the anterior wall rather than the posterior wall. So that fits. Can I have an AP on the left? So that fits with it coming from septal to lateral. Now, if I put my ablation catheter in contact with the anterior wall and you look at the signals, you can see that proximal is earlier than distal. So that again really strongly implies that this is right atrial flutter. It can't be mitral isthmus dependent because it's going from proximal to distal on the map, septal to lateral. And if this was mitral isthmus dependent, it would have to go round the back from CS 910 to 12 underneath the appendage and then hit the distal map first and then the proximal. So it would have to be the other way around. So I'm happy that this isn't mitral isthmus dependent. So my favorite at the moment is right atrial flutter. And if I do a couple of points.
Yeah, Richard, you did a beautiful and very didactic explanation what you do, and that's great. I think in the interest of, let's say, better understanding your signals, it may be good to sometimes give us an idea about or highlight the signals, because we sometimes just see the Carto in a pretty small way, the signals and orientation. So therefore, so I assume that the PV or the lasso, the former LA signals initially was yellow, and now it's the blue signals, correct?
I am very, very sorry.
From the spiral catheter?
I'm completely screwed. I'm going to have a look and see what you can see. Okay, great. Yes. So the lasso is yellow. The map is the white at the bottom of the screen.
Perfect.
And then on the Carto, you can see that the lasso is in the appendage and the map is on the anterior wall with the proximal of electrode closer to the septum. And the CS is in the CS with 1, 2 being at the bottom on the BARD and 9, 10 being the top of the green signals on the BARD. So we've got yellow is PV, CS is green, map is white. Perfect. Shall I just explain that again, or does that all make sense now?
Yeah, it helps.
Okay, so with the map in that position, we can see that proximal's earlier, distal's later. So it has to be going from septal to lateral, and on the CS, proximal's earlier, distal's later, so it has to be going septal to lateral. So it's going septal to lateral on both anterior and posterior walls. So it's very likely to be right atrial flutter. I've done a couple of points on the Carto, and red is earlier, purple is later, and that matches. So I think the only thing that we need to really confirm is that it's not roof dependent, and I'm just not picking that up. So let's go up to the roof, and what we should see is the activation on both sides go from inferior to superior. So I'm moving my mapping catheter up, and you can see that proximal is probably slightly later than distal on the BARD on the white signals. But let's take a point, and you can see that that looks slightly earlier than the red. And let's go to the posterior wall. PA view, please. And what I'm expecting to see on the back wall is activation go from superior to inferior. So white, light blue. And so it's going earlier, so inferior to superior. I think that's what I said. So both on the anterior and the posterior walls, the activation is going from inferior to superior. Can you just retime that one on the Carto, because it's not picked that up properly? And AP view again. So, Julian, does that all make sense?
It does.
Yeah,
Yes.
yeah. I think you nicely explained the activation wavefront given or the proposed macroreactant probably as the underlying mechanism, and I think you nicely elucidated the potential options. But still, I would like to ask now maybe Claire, ladies first, Claire's in your typical, let's say, workup on this very or not too uncommon clinical problem, would you, number one, expect also typically a macroreactant mechanism? And what is, in your experience, the most likely type of arrhythmias, and how would you tackle that?
Thanks. Yeah, I mean, I think that it's true that a macro-reentrant tachycardia is going to be the most likely outcome of this. But as Richard has already said, there's always a possibility of a micro-reentrant circuit, particularly around the veins where the previous ablation has occurred. I think I would have a probably similar workflow to Richard. I probably would have a little look at the right side first before I crossed onto the left, maybe because I don't have the, you know, if I was going to do a transeptal later in the case, maybe I don't have quite the restrictions of when to do that. So I probably would have had a look at the right side first, even though I knew that I was going to cross to the left to re-isolate the veins later. But apart from that, I think my workflow would have been similar. I think entrainment is very useful, but I probably do look at the activation map first and then use entrainment to confirm what I'm seeing or to help elucidate things if the activation map is not clear, for the reasons that Richard has said, that it can sometimes change things. But I do think entrainment is very important.
Yeah, yeah. And just maybe one brief comment from Vivek. I know Vivek would never have two gaps in one vein or one circle after cryo.
Can you show me the rotation on
So therefore, PV reactant tachycardia would not an option for Vivek. But apart from this, Vivek, your thoughts?
Opportunity to go back and look at a vein and re-ablate it if I get that chance. So I don't need much of a reason to look on the left side. Number two, however, my general strategy is in today's world of multi-electrode mapping, the potential for multi-electrode mapping, I like to avail myself of that. So look, in general, I don't know, some of this may have to do with approvals and availability, but we really liked using, at least with this mapping system, a multi-electrode catheter like an Octave, for example. You can get a very high density map very quickly. And it's not so much about elucidating the mechanism, though that is important. To me, it's more about in situations where it's not, for example, typical flutter, there's oftentimes a critical region. There's oftentimes something that potentiates the arrhythmia. For example, it could be a mitral isthmus-dependent flutter, but it could be that the place you ablate is not in the posterior mitral isthmus, but rather in an area anteriorly where there's pre-existing scar. And you oftentimes will find a single percolating electrogram. So that's why I tend to favor that. Again, ultimately, I think you'll get to the same sort of situation. But the beauty of that is, number one, you get to very quickly, literally within 5 minutes, you understand what the mechanism is. Number two, you have the potential for identifying a single site to ablate as opposed to making a line. And number three, I said this out of order, but number three, in terms of doing entrainment, which I love doing entrainment, I think it's good physiology and it cements the diagnosis usually. But when you have putative circuits, then you can do entrainments in areas where you expect to be in the circuit as opposed to be outside the circuit. So the chance of terminating with entrainment drops a little bit. So, you know, anyway, so those are my thoughts on this. And especially in this, if you look at the cyclone, there is some small fluctuation, not a huge fluctuation. So my guess is you probably have a reasonable size excitable gap, but, you know, we'll see.
All right. So thank you. Let's move on and see how far Richard got and what he did.
So what I've done is I've just now, while Vivek and Claire were talking, I've just pulled it back into the right atrium. And I've just done a brief map of the annulus, and you can see that that does fit with a typical right atrial flutter with the, if you look at the left hand, the right hand screen with the LAO view, we've got activation going from purple to red to yellow to round to green, past the hiss, which I've marked as a yellow dot, and then back to blue and then purple again. So I think we've got right atrial flutter. And so I'd normally at this point just do an isthmus line because I'm going to do an isthmus line anyway, and rather than entrain it and risk the joy of the AF, the flutter terminating with ablation. So if you're, with your permission, I'm just going to crack on and do that now, if I may.
Absolutely, go for it.
So we're using the Visigo sheath. I haven't connected up the visualization to it as yet. I'm using a force sensing F-curve thermical catheter, and I am looking for an FTI of 400 on a 40 watt power delivery on the right atrial isthmus. I may reduce it to 30 when I get down to the IVC end. Do you know why the visit tags aren't showing? Oh, there we go. It's just appeared. So I'm looking for the visit tag to go red when I've got a sufficient lesion, but I stopped early on this one because I couldn't see it developing. Normally I just do a drag back, just briefly stopping and starting with the RF just to reset the time counter on the visit tag, but essentially I'd be ablating almost continuously. I think that one of the things about doing a point-by-point, very didactic map is that I'm looking at the electrograms on the ablation catheter as I'm doing this. And if I'm doing a quick multipolar map, I always feel a bit uncomfortable trusting the system to automatically allocate timings. And in a short cycle tachycardia, where you've got a real potential for aliasing, I always wonder, doing it sequentially and building up the pattern in my own head rather than waiting for a final result allows me to understand the way that the activation is evolving and developing. So I quite like just doing it point by point because I'm beginning to understand where the activation is coming from in a progressive way rather than creating a whole map and then looking at it, the final results, which I sometimes find difficult to interpret.
Yeah, Richard, and yeah, also supporting at least your approach with the point by point. I have to admit that in Frankfurt in our center, we also are still, despite of all the great technologies with high density maps and creating a super beautiful and a couple of thousand points, we still like to have the information, clear-cut information from of maybe 100 points. If those are very clear and clearly understood, they are also very, very helpful. And I also think in our workflow, we would have also dare to entrain because we feel entrainment also gives a very good idea from the very beginning. But still, of course, going to left side and checking the PVs and closing gaps is, of course, also very, it is part of the this procedure as well. But still, I'm not, of course, I agree with Vivek and all the others who love high density mappings. We also love it. But still, I think 100 good points are very, very, are not inferior to maybe 1,000 points, I believe, if you look at them. And also, it's some joy looking at the electrograms.
I wonder if any of you have experience of ripple mapping, using the high density mapping tool like Octore or Pentare, because a bit like what Vivek said, one of the advantages of the high density mapping is that even though you will come to the diagnosis of, say, perimitral flutter, rather than creating an entire isthmal line, that high density mapping allows you to home in on those areas where the voltages may be low or the critical isthmus, so you can actually get away with limited amount of ablation. Also, in terms of micro reentrant flutters, I think that's where the high density mapping perhaps comes into its own compared to taking a limited number of points, which will give you the diagnosis for macro-reactant flutter very easily. But if you're dealing with complex flutters or dual loop flutters, perhaps higher density might help.
Yeah, I agree with you. Actually, I've published on a series of congenital heart disease patients who were exactly in that category. A lot of them had macro-entrant flutters, but there was quite a large percentage that had micro-entrant flutters, and we showed using very high density mapping helped in determining the best place to ablate, which wasn't always in the kind of conventional place, but was in the area where you could get the most out of the fewest lesions, basically. So you could create your line across the narrowest isthmus, which wasn't necessarily in the traditional place that you'd do an isthmus. So I think that multi-density mapping is very important in that respect. I do agree, though, with what Julian was saying, that if you're going to collect lots of points, there's no point in collecting a lot of points if they're not being annotated correctly, because you'll just end up with a big mess, which is worse than a small mess in some ways. So I think if you're going to collect lots of points, you have to make sure that you set up the criteria for mapping properly, and also that you check as you're mapping that they are annotating to the correct place, and if necessary, stop and retrospectively go back and have a look at those points.
Let me also, while Richard is continuing his ablation on this CTI, also just bring up the question, if you had a beautiful or a nice map with additional, let's say, disease, low voltage areas, which are not relevant, at least to the clinical arrhythmia at this point in time, would you also ablate it, or would you leave it? And if you ablate it, how would you ablate it? What are your thoughts, based on those 1,500 points?
So maybe I'll start on that one. I think that, yes, I think it's very useful. It would be very useful information. I didn't hear all of the history about this patient. I don't know if we heard it, but for example, let's say this is a patient who had previous cardiac surgery, okay? Then they have a right atrial scar, right? Because they had to instrument it. And so you'll end up, which obviously will also potentiate typical flutter. But these patients with right atrial scar oftentimes have more than one right atrial flutter. They'll have the typical flutter, and they may have a scar-related reentry, for example. So that may alter your strategy, meaning both typical as well as looking for the atypical. Let's say they have anterior left atrial disease, as oftentimes these persistent patients do. Then certainly your suspicion of micro-reentrant flutter or micro-reentrant anterior wall flutters start increasing. Certainly, I think that the fact that there's a PV reconnection is in some ways, given the fact that the patient has a recurrence, it's good because now you have the putative initiator for the flutter. So that's good. But you also have to think about other substrates. So yeah, I do tend to understand what the substrate is. Because oftentimes that'll alter how I think about the patient's particular disease process and potential lesion set.
Right, but just let's stick to this patient. As far as I understood, there was a previous PVI with cryoballoon, but nothing else. So PVI only ablation. Probably there's some underlying disease which we may detect during the extensive mapping. And if we terminated edge flutter, would you also, or who would also ablate potential low voltage areas and the anterior part of the left atrium, for instance? Would you go for prospective, or would you induce, or would you check history if there was other types of atrial tachycardias as well? So very practical standpoint, from a very perspective.
Yeah.
I got it, but look, so a couple of things. First, in this particular case, I would look for other atypical flutters by induction, okay, not necessarily empiric ablation. Number two, by induction. But number two, I would also look for other initiators. So after, I'm sure Richard will finish isolating the veins and everything. Once that's done, I actually would give high dose isopril and look for non-PV triggers because, unfortunately, the ubiquitous nature of PV reconnections belies the fact that, look, about 20% of patients or so, somewhere between 20 to 30% of patients have non-PV triggers. So I think you have to also consider that. So I'm much more interested in that in a patient like this than I am as opposed to necessarily homogenizing scars or something else I would be interested in someone who came in with a fib as opposed to flutter.
But can I just...
Let's go back to Richard. I
got-
think you changed something, right?
So we've terminated the flutter, and it terminated at the IVC end, and it's quite interesting. We're now pacing the CS, which is green, and then below that you can see the map, which is white. And as the ventilation moves the catheter back and forward, you can see the proximal signal get very late and then very early, and the distal catheter electrode swap positions with it. And if we look at the force sensing on the Carto, you can see that as they breathe in and out, there's a sort of ridge, and as they breathe out, the force goes, and so we're not able to get the tip in contact with that. And so that's probably a site of a eustachian ridge that we just need to try and find a way of getting the catheter in better contact. So I'm just inverting the catheter and sort of folding it back onto that area to try and get a more robust contact. And then hopefully we'll get conduction block across the isthmus, as well as having just slowed and then terminated the flutter. So it slowed before it terminated. We can now see the ablation catheter signal get later. If you look at the signals on the live, you can see the stim to map has gone out quite a bit now during that ablation. Not as quick as I'd like it to, but it's definitely prolonged. And so we're going to work pretty hard to make sure we test that properly, but it looks as though we may have got conduction block there. There's still a very low voltage signal. It's not quite as late as I want it to be. So I'm going to try again on that signal and see if we can get it even later.
So did you,
can
I
see
may
the
have
catheter
missed it.
just
Did you
wants
take
to
an
flick.
F curve or a D curve?
F curve.
An F curve.
Just because it just gives me a bit more flexibility on the getting down to the annulus and so on. And I think we've still got conduction through there. And again, you can see that phenomenon of when I've got it flat on there, mapping distal and proximal, swapping positions there with that very long signal on the map 3/4. Can you see that sort of really fractionated long signal there?
Yeah.
We
try and get
get a
my
sense
distal-
of it. We get a sense of it, to be honest. But it's not super clear to me. At least I cannot see it very clearly.
Can you just increase the gain, guys, on both maps? Bring it up to 32. And
Richard.
so now, can you see it a bit better there?
Yeah, it's a little bit better.
Just coming and going on the proximal and then the distal. Sorry, someone was asking me something.
Yeah, just a couple of questions relating to your ablation strategy. First is, do you believe in a particular intertag distance that you target when you're doing a focal line or indeed any linear lesion? And the second thing was, do you look at generator impedance drop to see if there are any weak links in your chain? Because with the FTI of 400, you're controlling the input all right, but you have no sense of the output. You have no sense of what's actually the tissue, how the tissue is responding. Whereas if you were to look at generator impedance, you perhaps may have a better idea of weak links along the chain.
Yeah, so I don't look at distance because I use a 2 mil Visitag setting. And so if there's a gap between them, then I'm not satisfied. So I'm just using the lesion, making sure that all the lesions are in contact with one another.
Sure.
So I think I just want to point out that we've got block now. That signal's gone, and now the map distal just to the side of the line is really late. And if we do a timing of stim to the map, it's 192. Can you just show that, swing that over to the other screen? So you've got 192 there. And then if I move it a bit more lateral, can you grab again and just time that and make sure it's shorter? Well done. Just make it up if you have to. Yeah, 178. So should we pace from map? We'll go back the other way. So we're just not that far lateral of the line. Can we pace from the map? And then just time the stim to the CS for me. And you can bring that onto the screen as well for them to see.
Hmm.
And it was quite interesting when you looked at the mapping signals on the isthmus, they were actually later than CS distal, and that's just simply because the CS is quite a long way around the annulus. Do you want to try and grab it now? So that's 190. I've moved the map closer to the line. Make sure this is later, Manpreet, otherwise you're in trouble. 196, okay, 198, okay, great. So I think we've got block, and we saw a definite step out in conduction time. So I'm going to go back into the left atrium to sort out that right lower. Yeah, thanks. So I've just gone back into the right atrium, left atrium. I'll swing the PV back onto the right lower. I'm very, very reassured by, we can stop pacing, guys. I'm not thinking about the patient at all because I've got Sachin, the brilliant anaesthetist, just keeping an eye on everything, making sure the ACTs are okay and that he's happy with everything, because we work together all the time. So he knows exactly what's meant to be happening. So if I'm distracted, he'll pick it up. So that's the PV right back at the os. And I think you can, I don't know whether you can zoom in on that screen, can you? On the yellow signals, 5,
There's
6.
Spiky signal.
Is, yeah. And it's pretty much just on that ridge between the upper and lower. So I'm glad I did stop and farting around in AF, because I think we've got a better idea of what the timing is now. It's just on that very typical area between the upper and lower vein where it's thicker. Can you put the map above 5, 6 on the BARD so we can time that out? So that should be a bit earlier, and it's not, it's later. So I'm in the wrong spot. So I'm going to go down a little bit more posterior. And that's still a bit later. I'm coming down towards 7, 8. And that's still not that late. So I'm going to go up the other way. I'm going to go between the veins because I'm getting late where I'm going. So I'm just trying to tuck it in to the vein there. That's really late. Can you see that? So on the PV, on the map, it's much later than the CS56. PV is 5, 6. So clearly going more anterior between the upper and lower vein is wrong. So I'm going to just hunt a bit more.
While you were mapping, Richard, maybe you just briefly tell us what you did in the index procedure. Did you do
just a
240 seconds application, 3-minute application? I mean, you have a very good outcome, 3 out of 4 veins isolated. Just to share it with us to have an understanding.
Yeah, sorry, it was a very good point. It's 180, 180 seconds, and I just do 1 freeze. I don't do bonus freezes. So I'm just going to do it.
Probably you know perfectly, yeah, the time to isolation for all those veins.
Well, interestingly, I'm much more interested in the time from the temperature from isolation to ultimate temperature, because sometimes I'll move the balloon to seal it off. And so for me, there you go, there's the isolation on the vein there.
Now it changed, yeah. Perfect,
yeah.
Wonderful.
So I'm much more interested in the point at which it isolates and then how far lower it drops after that. Because I'll often move the balloon during the freeze to try and seal off the bottom end, as you do. And so I think the time to isolation isn't as useful as the how much further it gets below the point at which it isolates, if that makes sense. So if I isolate at 40 and I go down to -50, I'm really happy. So
is it a typical gap site?
I think it is. You know, that junction between the upper and lower. Junction between the upper and lower is a pretty common one, but not for cryo, but in general, that can be a slightly thicker bit of tissue. What do you think?
Yep.
Oh yeah,
Certainly for
I would have
radiofrequency.
asked. Yeah, I would agree with Diraj. I think it was Diraj. Typically with RF, it is the posterior superior part on the right side where we observe gaps. With cryo, it's a little more different. I would have done exactly the same. First, we looked at the inferior aspect and also at the posterior region where you have been looking for it. And I think it is not the number one, but maybe number two region in my experience.
So is there anything else you guys want me to do?
Would you
So
try
what
and
about
induce
mapping?
another flutter?
Exactly. The bringing up the question of induction and doing more and looking for anything else.
I'm an Atul Verma disciple, and I'm a great believer that less is more. And so I always think every lesion I give has the potential of causing more trouble than it's worth. So in this situation, I wouldn't, because he's coming in a clinical tachycardia. As Vivek says, we've got a putative reason why it may have initiated. So for me, I'd stop here.
Okay. Do you mind if I ask a question
wonderful.
from Vivek? Because Vivek mentioned that he would use high-dose isopril to try and look for extra PV triggers. Now, in this case, given that we had one of the veins had reconnected, would Vivek, in your mind, would that satisfy you that you've got a putative trigger, or would you still go on to use isopril? And if you do, how are you going to use it in a practical way? I mean, what kind of isopril dose, and how are you going to use multipolar mapping to identify in the site of or the focus of any triggers that you might have?
Yeah. So look, one of the issues is that unfortunately, PV reconnection continues to be relatively common. So in that situation, unfortunately, while I would love to believe that the PV was the cause, and indeed, I still think it probably is the cause, just to be clear, it's still probable, probable is the wrong word, it's still possible that there's a non-PV trigger that initiated this. And again, look, the patient came in and fluttered. We don't know if they also had some episodes of fib or whatever, and that certainly would modulate your decision here. But I do tend to give isopril anyway. So in terms of how we do it, we like to give 20 mics of isopril, 20 mics per minute of isopril. That's the typical dose. And it's pretty high dose, which is what you want. Oftentimes you won't see anything happen. You got to wait, 10 minutes or so, maybe 15 minutes. Oftentimes we'll fibrillate purposefully with rapid pacing on isopril and then shock, because sometimes then you start seeing triggers. And if nothing there, then you're done. In terms of how to map it, mapping non-PV triggers is painful. There's no two ways about it. More electrodes and more catheters are good. I hear using a multi-electrode catheter like the Octaray is, I think, particularly useful for non-PV triggers. It's a big area, it's relatively dense, and I find it really helpful for non-PV triggers. And we typically start off putting on the posterior wall, wait for the trigger. I usually put an ablation catheter in the proximal SVC, looking on the right side, and between a CS, an SVC catheter, and an octopolar in the left atrium, usually with about 3 or 4 inductions, you can localize it pretty well. But again, look, I also appreciate if this patient mainly had typical flutter and not a lot of other, let's say, evidence of a fib, I can certainly appreciate stopping right now.
Claire, from your
I would agree with
workflow,
you.
would you ask for anything else?
Sorry, was that a question to me?
Yeah, would you ask Richard to map more maybe? And this is what I would ask him to check the vein and sinus rhythm.
I think it does very much depend on the context. Yeah, I think it's worthwhile just rechecking the veins in sinus rhythm, as you've just said, Julian. I think in terms of doing more ablation, I think in this patient, considering that they've presented in typical flutter and you've dealt with that and you've re-isolated the veins, then for me, that would be sufficient. I certainly appreciate what Vivek is saying about the fact that there could still be non-PV triggers there. I guess it's just a balance that looking for those is quite difficult. And I certainly find it quite frustrating because even if I'm using multipolar catheters, I don't find in a good percentage of cases that I can reproducibly find like a one non-PV trigger that I can then target. I tend to find that I get, non-PV triggers coming from a variety of different sources, and I find it quite difficult in practice to localize them. So I will do that if the veins are isolated, and I think it's very likely that there's a non-PV mechanism for this, but probably in this case I wouldn't.
So Claire has asked, so I will obey. I have already done it, but here's the left upper. I hope you can see the signals on the BARD. Yellow is clear. This is the left lower. And again, nothing there. Switching over to the right upper. That's all clear. And then I'll just slowly drag it back to make sure I'm not too far in. And it's clear all the way back. And then right lower again is all clear. I think that Vivek is absolutely right that just assuming that right lower is the cause is a bit optimistic, but I've just found that triggers, I just can't reliably induce them, and I've not found them helpful. So what I have done in patients with paroxysmal AF who are still troubled, even though the veins are isolated, is to induce AF and then make it non-inducible. So trying to make the atria intolerant of the AF rather than trying to find the triggers. And that has worked in a very small number of patients that I've tried it on, but otherwise it's a pretty desperate situation. Sachin has given 6,000 of heparin during this case without even telling me, which is wonderful. So he has just made sure that everyone is taken care of. I've taken the sheaths out, we've put a Z suture on, and then we have a little hemostatic pad that we'll put on before the patient goes home, and they'll be going home in about 3 hours.
Brilliant. Fantastic.
Yeah, wow, that's amazing. And also, I think, and this is, I think, very educative, and also you did a very didactic approach how to understand and how to come to the final diagnosis of CTI-dependent flutter. And I think this is, I think also we should not forget also looking electrograms, even taking this little tiny information, as Richard beautifully showed, distal, proximal, distal activation, what to expect in what region first, and then sort by sort, basically ruling out potential mechanisms. And then, of course, also taking out the energy and ablating and terminating the tachycardia. That was very, very clear. And also this apparently in a well-established outpatient scenario. So therefore, I think we can only congratulate to you on having performed this very, very didactic case. Still, I think there's open questions, many open questions. What to ablate beyond this right inferior PV, what to do with potential induced atrial tachycardia, potentially induced AFib. But this is the good thing. We still have a lot of room for future discussions and driving our own ideas. So this is actually what I would like to come up with. This very, very good case, and maybe just one last round and 30 seconds for each of us to summarize this case from individual perspectives. Ladies first.
Well, I liked very much the way that Richard kind of went through things in a stepwise fashion and kind of talked through the EP of it. And so you could understand his thinking as to why he was doing what he was doing at each stage. I think that, as we've all said, there are lots of ways of going about doing similar things, but the way in which Richard did it achieved the end goal very clearly.
Yeah. I agree. I just think it's very brave. I think it's very brave to take on an atypical flutter for a live case, because you don't know what you're going to do. And it could be anything. You could end up with a very complex flutter and you're going to finish it in an hour. So I think in some ways it was brave of him to do that. What this showed me was that common things are still common. So, even in the post AF ablation setting, CTI flutter still continues to be quite common. So that was quite good. But also I like the way Richard brought about the combination of a traditional EP, looking at electrograms, but also bringing out the strengths of the mapping system.
Yeah, I mean, I think we
Vivek,
start off
30
by
seconds.
we start off by saying lots of ways to do procedures. I think Richard got an excellent result. The only other point I would make is, even though the data doesn't necessarily support it, this is yet another reason why I like doing typical flutter lines empirically. I mean, the first procedure, that is.
Yeah, wonderful. So then, Richard, we want to and thank you again and your team in your center for this and I think this is our shared and takeaway, the very deductive and indicative and step-by-step solution of this case. And congratulations. Looking forward to the next rounds of cases. And thanks to the great panelists and the great discussions as well. And looking forward, ladies and gentlemen.
Thanks to everyone from One Welbeck, and thanks to all the panel for being very gentle with me.